Good morning. Good morning, everyone. I think people are still brewing some coffee out there. But we're ready to roll? I can't see if that's a thumbs up or down. It is. Well, we're going to stay on time for the folks like us that are on time, hopefully today. But good morning, everyone. Welcome back for day 2. I hope many of you all had a chance to continue yesterday's conversations during posters and Prosecco. I hope a few of you got to have some of the lobster rolls that I didn't have last night because they were quite good. And I hope some of you got out this morning for the Rock the Run. Thank you for joining in with that. I mentioned this before, but one of my favorite things about KCRS is looking at the conversations and hearing and feeling the buzz or the excitement around the room, or around the foyer, or in the hallways, or in the elevators even. The ideas that percolate around the coffee, beside a poster, during a meal, all of these things are important to be with your colleagues. And that's, I think we all know, is how collaboration begins. So really appreciate you all continuing that. And yesterday, I think we all were happy to celebrate some awards and also the remarkable science and the people that are behind that. Today, we're going to continue to look ahead. We're going to explore and hear more about some new therapeutic approaches, some emerging technologies, and the discoveries that have the potential to shape the future of kidney cancer care. Today, we're going to begin by recognizing our founding partner, Exelixis. Their long-standing commitment to kidney cancer research has helped advance care for patients around the world. And so if you could please join me in welcoming Tasha Hall, Executive Medical Affairs Director at Exelixis.
Thank you.
You're welcome.
So it's an absolute pleasure to be here today to represent Exelixis and speak to you all. And kind of as David just explained, I'm going to talk a little bit about the past, the current, and then the future with Exelixis when it comes to kidney cancer. So with that, in my short amount of time, I'm going to begin. So CABOMETYX is kind of reaching its 10-year anniversary this year since the initial approval in renal cell carcinoma. So we're very proud of what we've been able to do with this agent, not just in kidney cancer, which you see on the bottom of the slide, but also across other tumor types with indications in HCC, DTC, and then most recently in neuroendocrine tumors. And I think also for this research audience, it's really nice to note that 2 of these registration trials were run by a U.S. cooperative group. So I think that speaks to the collaboration within Exelixis with researchers like all of yourselves. And then there's been a lot of work behind the scenes with the correlative science from the samples that have been collected from these various studies. And you saw some of that data presented yesterday from COSMIC-313. So this is the slide that needs to be in here that lists all of our indications for CABOMETYX and then also the warnings and precautions. I just reviewed all of the indications for you in a brief manner. And then from a warnings and precautions perspective, you're familiar with those TKI toxicities. So just to kind of go back in time, the Checkmate 9ER trial was really kind of the pivotal move into a combination with CABOMETYX, which was cabozantinib plus nivolumab, as you're all familiar with, versus sunitinib. It did meet its primary endpoint, and there's 5-year follow-up data available. And I think we're really trying to work into what other information can be gained from this large database of clinical data and also correlative data to help better inform treatment decisions. And that's kind of where we're at now. The primary analysis for the primary endpoint is over on the left-hand side of the slide, and then you're seeing the updated analysis on the right. What was nice is that the medians held true for that long follow-up, and the hazard ratio remained relatively stable. From a toxicity perspective, we saw the TKI toxicities that you would anticipate, with hypertension being the most common grade 3/4 at 13%. And then we kind of moved to COSMIC-313, and I think this was Exelixis' attempt to kind of move the science forward with trying to add on to what already was an effective regimen with nivolumab and ipilimumab and comparing it to Nivo-Ipi as well. So this was the first frontline trial that had a modern control arm, aka not compared to sunitinib. The primary endpoint of this trial was PFS And although it met the primary endpoint from a statistical perspective, there wasn't any benefit seen in overall survival. And there was a lot of lessons to be learned from a toxicity perspective, specifically with elevated liver function tests when giving these 3 drugs together. In addition, there's been a lot of lessons learned from the correlative data, again, with some of that being presented yesterday. So even with a negative study, we've learned a lot about the disease and then also about the agent's use in the regimen. So now I'm going to move past Cabometyx and I'm going to move into the pipeline. So this is the disclaimer that this is all off-label, and we're certainly not advocating for any of these drugs to be used today in the clinic. So this is a snapshot of the Exelixis pipeline. I like it because it's done by tumor type, so it kind of gives you an idea of what that depth and breadth is of the Exelixis pipeline. So RCC, you're seeing it as the first column. Obviously, it's my favorite. That's why it's over there, like first up. But then you're seeing a lot of other solid malignancies that we're pursuing with a number of different various agents, and you can see those listed out there. I think initially Exelixis, we're a small company, we're US-based. We were really excited to start seeing our pipeline move from the lab and into the clinic, and we're starting to see the fruits of all of that labor now and into the future. So let's start with zanzalintinib because it's the furthest agent along within the pipeline. It's a multiple kinase inhibitor. All of the kinases that it inhibits, VEGF, MET, Tyro3 axle, these are the same kinases that are inhibited by cabozantinib, but there are some notable differences. When they were working to pursue the development of this agent, they were really trying to look for an agent with a shorter half-life than the 99 hours that you see with cabozantinib. And they achieved that. Oh, hang on. There we go, which you see here, which from 99 hours to 20 to 28 hours when you look at the phase 1 trial. But in addition, they did a lot of other work comparing zanzalintinib to cabozantinib in the lab, and they saw that there was some difference in the distribution. What you're seeing in the bar graph is a comparison of cabozantinib in blue to zanzalintinib in orange. And you're seeing that the distribution in the tumor tissue is the same between the 2 agents, but you're seeing less distribution to normal tissue, particularly skin, heart, and plasma. And they also wanted to kind of confirm these findings by looking at the MET inhibition, is what you see over on the right-hand side of the slide. Now, zanzalintinib has a large development program behind it, and it also has an open investigator-initiated trial program as well that's pursuing tumor types outside of what you're seeing here. This is really looking at the first study that was done looking at dose finding and then doing some dose expansion in tumor types where there was some efficacy either potentially to be seen or that was seen within that initial dose finding. For this audience, I'm certainly going to focus on the top, and that's the clear cell RCC data, which was from cohort A. We saw this data presented by Monty Paul, who's walking in now at IKCS in 2023. And so with this group, I think what was really exciting to see was this was a heavily pretreated group of clear cell RCC patients. They had had a number of prior therapies. All patients but one had had a prior PD-1. The majority had had at least one prior VEGF TKI. And we saw a complete response rate, or overall response rate of 38% and a disease control rate of 88%, which you're seeing on the curve. Then they looked further to see what was that impact of prior therapy. So what was the impact of a prior TKI, and then specifically cabozantinib. And you'll note that the objective response rate was lower in those patients who had had a prior TKI and lower in those patients who had prior cabozantinib, but there are still responses seen even in this heavily pretreated patient. And I think the kind of the note below the bar graph is important to note that 3 of 4 of those prior cabo-exposed patients had had disease progression on that prior cabozantinib. So I think in a way that this is giving us some clinical data to support that something different is going on with zanzalintinib compared to cabozantinib. This led to the completed phase 3 trial in non-clear cell, which I think many in the room are familiar with, which was the Stellar 304 trial. The study's close to accrual, and it was looking at zanzalintinib plus nivolumab compared to sunitinib, really trying to answer a question is this true, a TKI plus IO is better than sunitinib in non-clear cell the way it is in clear cell? So instead of making an assumption, proving the point in a phase 3 randomized trial. Primary endpoints are PFS and ORR with a key secondary endpoint of overall survival. And we're currently waiting for enough events to occur to be able to say something about the outcome of this trial, but we're getting closer. Now, when we look at the other phase 3 trials that are being done with zanzalintinib, the first one to start and the first one to close was Stellar 303, which was in non-MSI high colorectal carcinoma. This study was positive for its primary endpoint of overall survival in the intent to treat population, and it's been submitted to the FDA with a PDUFA date in December. So we're obviously very excited about that and awaiting that outcome. But there's other trials ongoing, and I think we're kind of keeping true to Exelixis' foundation of not necessarily going for all of those big tumor types, but really looking at those areas of unmet medical need. You see a study listed here in neuroendocrine tumors. There's also a phase 2 study in meningioma that's not listed here. So I think we're kind of keeping true to our roots, but also expanding a bit further. And then over in the far right on the RCC studies, there's also a collaboration with Merck where they're pursuing the combination of zanzalintinib plus belzutifan. So now we'll move to the last topic, and this is the one I was really kind of working fast to get to. This is the agent that I'm most excited about from our pipeline, which is XB628. So let's talk about this. So XB628 is a bispecific antibody. It targets PD-L1 and NKG2A. That provides you with simultaneous inhibition of both adaptive and innate immune checkpoints, and it also acts as an NK cell engager, co-localizing NK and tumor cells. There has been some anti-tumor activity that's been seen in vivo and in vitro, and some of this data was presented at AACR in 2025, and we'll go through a little bit of the data that was presented on that poster. Before we really jump into that, though, let's just level set with what is NKG2A. So it's an immune inhibitory checkpoint. It's expressed on natural killer cells and also CD8 positive TIL cells that bind to HLA-E. And then HLA-E, its expression is upregulated on tumor cells, and it acts as a potential resistant mechanism to PD-1, PD-L1 blockade. So that's kind of the rationale behind the combination. Now, there was a study done in non-small cell lung cancer by AstraZeneca, the phase 2 COAST trial, which you see the data on the slide here. This was looking at durva alone compared to durva with an NKG2A inhibitor, which is monalizumab. And what you can see is the PFS and the overall survival was greatly increased with that combination of the two agents compared to durva alone. So that's kind of the background rationale. This is just a snapshot of that poster that was presented at AACR in 2025. Not for you to be able to read it, but more to the point that there was a lot of data that was contained within this poster, and I'm just going to highlight a few of those figures that were in the poster for the sake of time. So this again gets into that proposed mechanism. It's recruiting natural killer cells to the tumor in order to promote tumor cell killing, and then it releases the two inhibitory checkpoints. So one of the first analysis that was done, which I think kind of sets XB628 apart from giving the two agents individually, was this one. And this was looking at the co-localization that I noted before, where you can see that it's occurring with XB628, which is the circled, marked section of the graph of the tumor and the natural killer cells. It did not occur when you look at the two antibodies individually or with the isotope control. Then they also looked at the whole natural killer cell side of things and the ratios here. And here you're seeing in the top bar graph, which I think is the most notable on the slide, that there was significantly greater mediated tumor cell death by NK cells when you look at the combination compared to the two drugs individually or on their own, or compared to the isotope, which again, I think saying something about this co-localization and the bispecific antibody nature of this molecule and what it's doing on a preclinical level. Finally, there's some dose dependency that was seen. This is going from isotope control at the top all the way up to 20 milligrams per kilogram. So these are all of the author's conclusions from the poster. I noted there was a lot on there beyond what I just went through, but I think that this preclinical data has set us up to really want to pursue this molecule alone and potentially in combination with zanzalintinib, which I reviewed before. And that's leading us to XB628-101, which this is the dose-finding first-in-human study looking at the agent alone and in combination with zanzalintinib. This study is open. I know I'm looking at some investigators that are participating in this trial in the audience, looking for the MTD, the DLT, and then once you get to some of the dose expansion cohorts in different tumor types, then you're starting to look for efficacy like objective response rate, and one of those tumor types being pursued is renal cell carcinoma. So with that, and I nailed the time, just so you know, I've been keeping track. This is just the final slide that I want to show, and I think this again just gets to why we're excited. We've got more agents beyond the ones that I've reviewed with you today that have moved to phase 1, and we're really anticipating that we're going to have more agents move from the lab to the clinic with an Exelixis in the coming years. And with that, thank you.
A question.